Welcome to the 10X Health Educational Webinar Series. Shortly, our invited physician will begin their session.
Okay, thanks very much, Juggy. Just want to thank everybody for tuning in here, and me and myself and Dr. Switzer just wanted to discuss with you guys a little bit about 10X treatment. It's a novel treatment of chronic tendinopathy, minimally invasive image-guided percutaneous tenotomy and fasciotomy, and kind of share our experience of why we got into starting to perform this procedure, what interested us, kind of the pitfalls that we went through and how we dealt with those, and hopefully we can help you guys get your practice up and going. So our practice here in Phoenix is a hospital-based practice, but we do have a dedicated IR clinic where we see patients half a day each week, and that's expanding as our patient increase. There's two of us that are full-time interventional radiologists. We do some angiographic diagnostics, but mostly we're full-time IR rads. We do pretty much the full spectrum of IR services, everything from simple procedures, biopsies, paras, thoras, up to EVARs and high-end oncology work. We have a diverse patient population, and mostly we serve the we provide care for the underserved community here in Phoenix. A little background on tendinopathy. This is one thing that definitely piqued my interest when I started looking into this, is just how big of a problem that tendinopathy is. Over 10 million Americans suffer from chronic tendon pain, and I think once you start looking into this, you'll find out that there's lots of people that you know that have chronic tendon pain. We're defining chronic tendon pain as tendon-related pain that's of a duration of 3 months or longer. And chronic tendon pain usually results from overuse activities which cause repetitive micro tears in the tendon's collagen fibers. And the collagen fiber micro tears initiate a cascade of degeneration leading to pain and functional limitation, which causes the patient's symptoms. You may or may not know all the treatment options that are typically employed for tendinopathy. I think this is something for me as an IR that I wasn't super familiar with until I started the education process and really speaking with my peers about how these are managed. Traditionally, the treatment has been rest, which isn't really very effective and restricts patients' daily activities. They can't do the things that they love, and you can only rest these injuries for so long before you want to go out and do what initially caused them in the first place. There's a host of anti-inflammatory medications, different injections, whether it be anesthetics, steroids, or the newest craze is kind of platelet-rich plasma injections. The interesting thing about these is the medications obviously attempt to halt inflammation and mask pain. The steroid injections actually inhibit some of the inflammatory reaction, but over time can actually make the tendinopathy worse. And then platelet-rich plasma, there's a lot of different things out there about this, but the concentrations and the method of delivery for PRP is so varied between each practice that it's really hard to find any meaningful data on anything in that realm. But those are some of the treatment options that mostly are being employed now. Also, physical therapy. It's a good adjunct to rest and injections. However, it's really not very convenient for the patient. It's tedious, and usually they somewhat plateau at a level of relief that's frustrating for not only the patient but the therapist themselves. The most definitive treatment that's traditional is either an open tenotomy or fasciotomy. This is a treatment that actually does provide very good relief for these conditions. However, it's a fairly invasive procedure, and the recovery period is usually about 12 months, where they can't get back to their regular activities. So it's not something the orthopods typically like to do because it's not a very satisfying procedure in the long run because the patients require so much recovery period. The advantage that tenotomy and fasciotomy does have over the other procedures is that it actually removes the scar tissue, which is the inciting of pain. The procedure that I want to talk to you all about today is percutaneous tenotomy and fasciotomy. This is a novel, a new take on treating chronic tendon pain. It's a minimally invasive therapy. It's ultrasound guided, and the image guidance allows for precise treatment of only the damaged area of the tendon or fascia. I don't know if you can see my pointer, but you can see in the upper left-hand picture there's the TX1 microtip handpiece, which delivers an ultrasonic frequency, which is specifically calibrated to break down damaged tendon tissue. It provides no damage effect to normal tissue, which is a distinct advantage of this technology. The broken down diseased tissue is then simultaneously aspirated and removed by the same instrument. So not only are you breaking down the diseased tissue, but you're actually removing it as well. The procedure is very advantageous in the fact that it only requires local anesthetic and a small enough incision to get your needle in, which is about the equivalent of 18 gauge. It's typically performed as an outpatient, and a typical treatment lasts approximately 20 minutes. So it's really a fast procedure. It's convenient outpatient with minimal sedation. This movie animation kind of shows you how the procedure is performed and what's going on inside the body as the microtip is delivered. So you can see here with the ultrasound, you deliver the tip under ultrasound guidance, and then you put it right into the scar tissue, and then the irrigation and the ultrasonic energy start going, which is deployed by a foot pedal, which you control independently. And you can actually visualize on the ultrasound, and you can even feel with tactile sensation the scar tissue debriding and going and being removed. So this is kind of a nice graphic that shows that. I just want to present a little bit of the literature that is pertaining to this instrument. It is a new procedure, and the data out there so far has been very good. This is a study looking at lateral elbow tendinopathy. In 20 patients, DAS score is the 0 to 10 pain score, and DASH score is a disability of the arm, shoulder, hand score, which is both are typical outcomes that are looked at in tendinopathy procedures. And you can see from the time of treatment with follow-up all the way to 24 months, patients are seeing a dramatic improvement in both the VAS and DASH scores, with continued improvement all the way up to 24 months. The most improvement obviously occurs in that first month. 95% of patients were pain-free at 12 months, and there were no complications. Another study looked at patellar tendinosis or jumper's knee. 16 patients, again, no complications, excellent pain relief and recovery, and these were actually 10 high-level athletes that were involved, and they all resumed their prior level of activity at a pain-free level. This study looked at various different areas in the body, the elbow, shoulder, knee, and Achilles, and as you can see, all the results were positive with significant reduction in the VAS scores after 10x therapy. Just another study, and this is really just to give you an overview that there is literature out here that supports it, and that all the literature does show this procedure to be very effective. The procedure is very safe. It's been performed over 15,000 times in the U.S. since 2012. The most common problem after the procedure is mild soreness, and this is typically managed with over-the-counter Tylenol. There's only been one reported major complication, and that was one incision site infection, and that was not in our practice. So as an IR, why was this intriguing to us, or why should you be involved? I think the biggest aspect of it was that tendinopathy and fasciitis is a huge problem, and the more I looked into it, and my partner, Dr. Switzer, the more we found just how many patients suffer from this disease. We found several patients that were just technologists in our own department, and even when I was on a plane, kind of looking at the name is eluding me right now, but the shopping magazine on the plane, there's like 45 different items in there related just to plantar fasciitis itself, and that kind of told me, man, this is a big problem. And talking to the people that actually treat this, there's no great solution. The podiatrists and the orthopod, some of their biggest complaints are their patients with plantar fasciitis or chronic tendinopathy, because they can do things to temporize it or to stunt it, but it never goes away, and ultimately it's not a great satisfaction for them because they're never providing great relief. And so I saw this procedure as a potential game changer to provide a therapy for a problem that doesn't have a great solution currently. The other thing that was great about it from an IR perspective is that it's image guided, and that's what we do every day, is we put needles, or we direct needles into different tissues, and it just seemed like a natural fit from an IR perspective. So I kind of alluded to this, but why IR? Minimally invasive therapy is what we do. It's image guided, and as IRs, I believe that we're the expert in ultrasound guided procedures, and if there's something to be done ultrasound guided, I think it's best done in our hands. The 10X procedure, even though it was treating a different disease state that I wasn't initially familiar with, the procedure became second nature because I've essentially done it a million times, just not on a tendon. So why your IR practice? This is a great opportunity to expand your referral base. Your orthopods, your podiatrists, your family care docs that may not be sending you a lot of patients, this is a great way to provide them a solution to help them with their patients and kind of get your name in the door. And believe me, you'll see benefits down the road with other procedures. It's quick, and it's an outpatient procedure. This is very easy to adopt. It's not going to provide you a lot of call burden. It's not going to have to be done on the weekends or have patients that are inpatient in the hospital. It's very easy to perform. The reimbursement is excellent. If you look at the financials, I'm sure your reps can provide you the information. But the reimbursement is great and usually very favorably looked at by your group or your hospital. The risk profile is really low. Like I said, there's been one infection in 15,000 procedures, and the complication rates are very low. And ultimately, patients are extremely happy. You provided them a therapy for something they've been frustrated with, oftentimes for years, and that to me is extremely exciting and rewarding. So our experience with 10X. So initially, I found out about it from a fellow IR who was performing these procedures and telling me the great experience he had with it. So we decided to look into it, and this is how we went about it. After we discovered that 10X was out there and that we thought it was a good idea, we formed a business plan. We provided this to our hospital execs. It was a concise plan which we laid out the epidemiology and the need out there for this therapy, the equipment costs, reutilization, and projected reimbursement. Credentialing was probably our biggest hurdle, and this was probably a couple things that were somewhat unique to our institution, but also can be experienced anywhere. But the 10X reps and execs were extremely helpful. I can't emphasize that enough. We had to jump through a lot of hoops, and they were patient and helped us jump through all of them. But we were the first IRs in Arizona to perform 10X, and the credentialing committee was definitely not familiar with the procedure. And so trying to explain to them that we do this procedure a million times a day, just in different forms and not on a tendon, seemed to them like we were performing an entirely new procedure and trying to be orthopods and doing something that wasn't really IR related, which was difficult for them to understand and difficult for us to understand at the same time. But after a lot of talking with them and going through it, we came up with a plan to get credentialed, and that included Dr. Switzer and myself each performing the 10X procedure on 5 cadavers, which the 10X faculty worked with us. They actually brought the cadavers on site to us, allowed us to do the procedures on the cadavers here at our hospital, gave us a certificate of completion, which helped us in our credentialing process. And then both Dr. Switzer and myself had to do 2 procedures on patients with a proctor, and Dr. Gill came down to Phoenix and proctored both of our cases and shared a lot of his knowledge with both Mike and myself. once we were able to do all that, we were able to meet all the credentialing requirements, and now we're officially credentialed. The other parts of starting up this practice is getting the equipment in. The 10X console and the handpieces are readily available from 10X. They were great about getting us a machine out basically as soon as we could ask for it, and also the probes. The startup costs are nominal. You can discuss with your rep, but if you commit to a certain number of probes, they have provided the console at no expense, and so to get started, it literally is not very much money at all. The reps also have provided great support with our biomed team to get the machine pushed through and available for use for us. And then staff training, 10X reps came down. They were great with our staff. They helped multiple in-services on exactly how to use the console, how to hook up the handpiece, and everything that we would need. The console itself is very simple. It has a few buttons. I haven't messed anything up on it yet, and it seems like it would be hard to do. But it's a very easy setup, and not something that you have to go away to a course or that's really labor-intensive. The biggest thing for Dr. Switzer and myself was probably the physician learning curve. This is kind of a new area for our practice. In my IR training, I didn't do really anything with tendinopathy other than maybe some joint aspirations or injections. So learning just the anatomy of all the tendons and how to visualize them on ultrasound, see them on ultrasound, know what's pathologic and not pathologic. It took a little bit, but we ultrasounded a lot of normal tendons and looked at the literature, and after, just like anything, if you do it enough, then it starts to become pretty easy. The other things that we really had to do our homework on was starting to understand the disease process and exactly how tendinopathy occurs, the micropathology involved, and how exactly this therapy uses it, how it's different than all the other treatments that are out there, and why this treatment is better or should be considered alongside the other treatment modalities that we talked about at the beginning. Clinical exam, how to see these patients in clinic and how to elicit their pain, and how to see, is this really being caused by their tendon or is this some other process that's causing the pain, and evaluate them for this procedure, see if they're the right patient for it. And then also just the ergonomics and skills of doing the procedure. And after the procedure, what is done for these patients and how should you follow them up. There's a whole protocol that we kind of went through and developed with the aid of Dr. Gill and some of the other practitioners around the country that are doing 10X on exactly what we need to do for these patients afterwards, whether it's a boot or a sleeve, how much activity they should be able to do when they can return to activity, weight bearing, and all those sorts of things. I'll kind of go through our procedure, our protocol for that here in a couple of slides. But definitely we learned a lot from Dr. Gill and also a couple of our peers that are performing the procedure around the country that were more than gracious in their time and talking with us. So when do you want to consider performing 10X therapy? These are the various areas that are currently being treated. I think in the future there's probably going to be other areas as well, but right now these are the most well-studied and the ones at least that we feel comfortable with. Medial epicondylitis, lateral epicondylitis, patellar tendinosis, Achilles tendinosis, plantar fasciitis, rotator cuff tendinosis, and how we're beginning out is we're treating patients who have had symptoms greater than 3 months. And we think that patients should at least try to undergo one conservative therapy before we offer an invasive treatment, and whether that's rest, physical therapy, analgesics, steroid injection, PRP. We usually ask that they've at least failed one of those first. But what you'll find is most of these patients, when they get to you or when they seek attention for it, already have the symptoms for at least 3 months, much longer. And then patients who desire a non-operative treatment with a fast recovery period. A lot of these patients are looking at getting open tenotomy or fasciotomy, but don't want to have the post-procedure rehabilitation period of a year. and I think this is an ideal treatment for those patients. So how we do it here is we ask the patients for a pre-procedure consultation. We usually get a referral, and then we see them in clinic. We go through the history and evaluate their areas of pain. We do a limited ultrasound, usually in our clinic. We just make sure that we see the disease portion of the tendon and that their symptoms match up to what we're seeing on ultrasound, and that they'd be a good candidate for the procedure. We talk with them in detail about not only the 10X procedure, but the other therapies that are out there and that would be options, and then also what they can expect if we do proceed with 10X therapy in the post-procedural recovery period. So we answer any and all questions that they have. And then we do the treatment. It's an outpatient procedure where they come in and leave the same day. In our post-procedure protocol, if it's a foot, we have no weight bearing for 24 hours. We have them do intermittent ice application a couple hours for the first 24 hours. And then for the next day, intermittent heat application for 48 hours. If they do need anything for anesthesia, we try to avoid ibuprofen because we actually do have some inflammatory response to promote that healing response for the tendon. We'll put them in a walking boot if it's an Achilles or a plantar fascial treatment for at least 2 weeks. They can start walking on it the next day with that boot, and we try to encourage them for 2 weeks to stay off their foot as much as is feasible. And then after 2 weeks, they can take off the boot, and if they can walk in a comfortable tennis shoe without pain, they can leave the boot off. If they're still having some pain, we ask them to put the boot on, and we see them back in the clinic at 4 weeks. With the elbow, we have them just wear a compression sleeve for the first couple of weeks. We have them do full range of motion immediately after the procedure to avoid a frozen joint, and we have them gradually return to activity. And again, we see these patients again in clinic at 4 weeks. I should have mentioned too that we do call the patients the day after the procedure to see how they're doing, and then a follow-up call at 2 weeks to see how they're progressing. We have them return to moderate activity at 4 weeks, and if they're feeling good, we give them no activity restrictions at 6 weeks. They can do dynamic activity, jumping, weightlifting, whatever it is they want. So how are we getting patients, or how are we promoting this procedure? Because this has not typically been something where patients just show up at your door as an IR. So we've developed presentations that we've been given to the podiatrists, our orthopedic surgeons, physical therapists, our pain clinic physicians, PM&R, and also starting to reach out to primary care physicians as well. It's actually been very well received, and you'd be very surprised how many of the orthopods are like, man, this is what I bang my head against every day in clinic. This sounds like a great solution. And we've started to see some referrals from that. I do think it's important when you're presenting this procedure, particularly to the orthopods and the podiatrists, that you drive home the importance that it's a precise image-guided procedure, in that you get a lot of questions from your orthopods, your podiatrists, that when you do this procedure, you have to be right into the diseased tendon, or the ultrasound waves kind of transmit through a general area and it'll suck out the diseased tissue. And I think that's synonymous with a lot of the injections that we are either not image-guided or targeted a general area, but as IRs, we're very capable of putting a needle into a tiny little millimeter spot that we can be directed into. And that's really why I think IR could be the ones performing this procedure and really differentiates us from our orthopedic and partners. So outpatient experience, so far we've done several treatments. I can't even tell you how overwhelmingly satisfied our patients have been when we did our 6. We saw most of our patients in 6 weeks in the clinic just due to some scheduling stuff, but most of our patients have suffered for months, and in some cases years, with multiple different non-surgical modalities for treatment. And to a patient, there's not one that hasn't got significant relief, thought that it's provided more relief than any procedure or therapy that they've tried, and wouldn't undergo it 10 times over again. Just a couple of anecdotal patient stories. We had one patient who is actually the CFO of our institution, and he came to us because he found out that we were doing this, and when we were initially getting credentialed, we did our first 4 procedures pro bono to get our credentialing. And he heard about it, and he just came down out of the blue and said, I have plantar fasciitis. So we did an ultrasound, and he had one of the thickest plantar fascia that I've ever seen. We said Dr. Gill, when he was here and saw it, it was pretty rip-roaring. He had a lot of tiny calcifications in it, and we provided him with treatment. And I just saw him in clinic last week, and he said, you know, when I came to you, my pain was 9 out of 10 every day, and I couldn't take my dog for a walk, and I really couldn't enjoy doing anything anymore because I can't walk. He's like, I take my dog for a walk every night, and thank you for letting me have what I love to do back. And that was awesome for me. I mean, it just kind of sealed the deal for me that this is a procedure I want to be doing and offering for my patients. We also had another patient who had epicondylitis, who's one of our techs, and so we saw him every single day after the procedure. He couldn't lift patients for 2 weeks, but he is absolutely pain-free, and he's trying to tell me about all the weight he could bicep curl the other day, which I thought was kind of hilarious. But all of our patients are doing well, and I'm going to turn it over to my partner, Dr. Switzer, here for a minute. He's going to tell you about a couple of the patients that he's treated.
Hello, everybody. Thanks for having us. Yeah, real quick, I just want to talk about a couple of patients that I treated. First was one of the nurses that works in the pediatric unit of our hospital. She's a 57-year-old woman that has had lateral epicondylar elbow pain for 25 years. And she's tried a various assortment of treatments, including acupuncture, physical therapy, injections, and had kind of reached her limit and heard about us and freely volunteered to have something done. And at about 6 weeks, well, I saw her a couple times in the hospital and checked on her through the 6-week kind of follow-up post-procedure time. And after a couple of weeks, she was encouraged that she was having less pain, but still had a little bit of pain. A little bit of pain after the procedure. But at the 6-week follow-up, she had graded her pain as high as 9 out of 10 times, and she was so happy that she could now sleep without pain. At night, she had been in pain previous to the treatment, and she was so happy that she could sleep at night and was pain-free at night, and very satisfied with the treatment she received. Another patient we did was a 48-year-old gentleman that he had had foot pain for like over 6 years, he said, and more recently he was actually diagnosed or told he had plantar fasciitis. Knew the reason for the cause, but didn't have any successful treatments. He came to us, we were able to treat his plantar fasciitis successfully, and now his return to work, and quite satisfied with his treatment as well.
All right, thanks, Mike. So, in summary, sorry, we're getting some background feedback here, but in summary, I believe that performing the 10X procedure for your referral base is a huge opportunity to expand your practice, and the number of patients that are out there that are suffering from this disease process almost makes your referral base and your potential for patients unlimited. There's a huge untapped IR market, I believe, in this area. It's very easy to implement in your practice. I think we kind of touched on the steps we went through, and it was extremely easy. We did it in about 6 weeks from a business plan to first patients. It's an opportunity for you to provide a truly game-changing therapy for a lot of patients that right now, if they're not being offered this therapy, have very few good options. I believe IR is absolutely the right place for this technology. I think our skill set makes us the ideal practitioners to perform this. It's just a matter of working with your referral base and showing them how your expertise can benefit patients with this procedure. And overall, the patient outcomes are extremely rewarding. I think that's why we all do what we do, and seeing just the gratification from your patients that have suffered for so long without a good option, and this is extremely satisfying and one of the most satisfying procedures that we perform. So now we're going to take some of your questions. A lot of them have been sent to me over the messenger, so I'll try to read these out and address them as we go. The first question was, where should this procedure be performed in a radiology procedure room? Right now, for reimbursement, I believe that to get adequate reimbursement, it has to be performed either within a hospital setting or in an ambulatory surgery center. And maybe Juggy can touch on that later. But ideally, all you truly need for this is an ultrasound machine and a patient table. It can be performed in a very limited ultrasound room, but you do have to do it in a hospital or an ambulatory surgery center to get the maximum reimbursement. But the actual aesthetics of the room that you need are very minimal. Almost everything comes in the kit that they provide you, so you don't need much. But I believe just any general procedure room would be fine. The second question is how much out-of-pocket is required to get started. I'm assuming that everybody kind of hit the same pricing level. But with that assumption, what we did was we purchased 3 probes or 3 handpiece kits, which I think retail around $100, give or take. And with that guarantee to purchase the 3 handsets, then 10X will lease you the console at no cost. And I believe if you perform 50 or so, and please confirm all of this with your rep, but around 50 or so procedures, then the console is yours to own at no cost. I believe that's kind of the agreement that we got into. So the startup costs less than $3,000, pretty minimal. And you also have to have an ultrasound, but I'm assuming as IRs, most of us have those. How often do you see your patients after the procedure is the next question. So what we do is we call our patients the day after just to see how they're doing, and then we do another follow-up call at 2 weeks and just talk to them about if they can take off their boot or take off their sleeve and just generally see how they're doing. And then we ask the patients to return at 4 weeks or somewhere in that 4-week window to do a procedure evaluation. And really, so far, in our experience has been to kind of release them to returning back to full activity. All of our patients at 4 weeks felt great. They had reduction in their pain by about 90%, and it was more or less just to tell them, okay, you can kind of try to get back to stuff you love doing. And jump in here, Mike, if you have anything else to add to this. But the next question is overall treatment. So far in our practice, anecdotally, it's been, in my mind, 100% successful. I mean, we have a couple of patients where the pain isn't completely resolved, but it's now a 1 to 2 out of 10, where it started at an 8 or 9 out of 10. And so, in my mind, these patients have never got it anywhere close to this degree of relief. And as the data has shown, most patients continue to get relief through 24 months, that their pain continues to decrease. So I'm hoping that these patients, by that time period, will be pain-free. Okay. Can you briefly walk us through the patient experience from the waiting room to recovery to follow-up? How much time does it take to set up, to do procedure, post-op instructions, etc.? So we have our patients come in. We don't require any blood work on the patients unless they're on an anticoagulant, in which case we get a simple CPC INR. Otherwise, there's really no reason unless you have some concern for bleeding. We have them arrive an hour before the procedure, typically just for nursing to do their check-in and paperwork and get them set up. We actually do the procedure kind of in our ultrasound procedure area, and we place them just in a regular hospital bed for all intents and purposes. And if we're treating the foot, we kind of prop up their foot in position. If it's an elbow, we like to set it up on a Mayo stand in either abduction or adduction, and to open up whichever tendon we're going for. Usually then we just confirm again where their point tenderness is, and confirm with ultrasound that there's a lesion there, and we put a little X marks the spot on where we intend to treat. Then it's just a simple prep in the machine setup. It really takes about 10 minutes just to unwrap the materials, hook the machine up, and the saline, and give it a test. And you're pretty much ready to go. At that point, it's lidocaine, a small incision, and inserting the microtip probe into the lesion, doing your treatment. Depending on the lesion, we've done as little as about 4 or 5 minutes of just putting the needle in I did over 20 minutes on that plantar fascia that I was telling you about, which was a relatively long procedure. But I would say total amount of time from the patient getting into their bed, prep, procedure, and putting a Band-Aid on afterwards is usually probably about 30 minutes. Afterwards, recovery. There was a couple patients just in our initial phase that we did give some moderate sedation to, just because it was our first procedures and we wanted them to have a great experience as we were kind of learning it ourselves. So we had them recover for an hour. Otherwise, patients can literally go home, 20 minutes after the procedure. We get them fitted for a boot if it's an Achilles or a plantar fascia. We have the boots stocked here in our facility. Our peers or other people I've talked to, some people have them write a prescription and they pick up the boot prior to the procedure or right after. We like to just have it here for them. You can give it to them. That way they walk out of here with it and we know that they've got it. Post-op instructions, pretty much that protocol that we went through earlier is what we do. We have a little sheet that we typed up that kind of says no weight bearing for the first 24 hours. If it's an elbow, we tell them to do full range of motion, and then the ice packs intermittently for 24 hours, and then the next day starting with intermittent heat packs for 48 hours, Tylenol, and to try to stay off their foot as much as possible for the first 2 weeks and wear that boot, and then try and taking the boot off after 2 weeks, and just our contact information if they have any questions. But that's really quick and easy for the patient. Overall, I would say the total patient time in the hospital is probably a little over an hour from literally walking in the door, having the procedure, getting everything they need to walk out. How do you get credentialing is the next question. I don't think you actually have to get credentialing from Pennex itself, but it was literally our hospital and our medical group requires that we be credentialed for any procedure that we do. I would think that most hospitals or ambulatory surgery centers would actually, and we initially tried to do this, was to get this included under our general radiology ultrasound guided procedures credential, because in my mind it does fall under that. But our credentialing committee had I don't want to say misunderstanding, but they seem to think that this was some really novel thing that we don't typically do as far as guiding needles into different areas, and so they wanted to make it a special credential. And so to be able to do the procedure here, we had to get special credentialing specifically for that procedure. A lot of places have special credentialing for like vertebroplasty or like cerebral angiography, stuff like that. And so the credentialing process was similar to that. is 10x paying us for this presentation? We are getting reimbursed for this presentation, but I can tell you that we've not been coached on any of the outcomes or anything that to say on this procedure. This is really our experience and what we've gone through, and we're believers. Whether or not we're getting reimbursed or not, I'd be saying the same things. Have you ever repeated a procedure if you felt like it was incomplete? If not, would you in this case? We have yet to have to repeat a procedure. All of the patients experienced considerable pain relief, and any pain that was left over was different than they had pre-procedure. I suppose if I did do this procedure and the patient didn't get relief and they still had pinpoint tenderness and there was still a visible lesion on ultrasound and maybe I felt like I missed it when I was treating it, then I would consider retreating them. But I haven't had, the area hasn't come up in my practice. But I don't think there's any contraindication to retreating them. Their risk profile is very low, and I don't think it would be doing them a disservice if you attempt it again.
And I'll just add, in my discussions with the patients before the procedure, I did let them know that it is a possibility to retreat them. We haven't had to retreat them, but I did introduce that before the procedure just to get that in their minds in case we did have to retreat them. But that was because we had done a lot and we were just starting out. But we haven't had to retreat those patients.
All right. The next question is, do you prescribe pre-procedure meds for all your patients? Example, Ativan. And do you prescribe pain meds post-procedure? Example, narcotics. We have not been prescribing pre-procedure meds for any of our patients. I wouldn't hesitate to give a patient Ativan if they have extreme anxiety about the procedure beforehand, or give them light conscious sedation with some fentanyl or Versed if they had a high degree of anxiety. But the patient or the procedure is really well tolerated, and I haven't had anybody that has felt otherwise about the needed pre-procedure medication. Post-procedure meds, right now we're giving Tylenol or recommending Tylenol. That seems to have been more than sufficient. But I do tell all of my patients that I'll call them in the first 24 hours, and if they're having significant pain or that they feel like the Tylenol isn't doing the job, I wouldn't hesitate to write them a low dose narcotic. I know some people that are doing that routinely, but so far we haven't had anybody that's been in enough pain that needed. Would you be comfortable referring back to primary doctor for follow-up after the procedure, or do you feel that you should keep them back? This was actually a question I definitely had when we first started this. Was, I want to have the physicians keep sending me referrals, and I don't want them to view me as stealing their patients. But after doing a few of the procedures, I didn't want it to be like some of the IR procedures where we don't do a pre-procedure consultation. They just are scheduled by their primary physician, and they come in not really knowing everything about it and do the procedure. I found that the pre-procedure consultation really helps the patients understand what to expect and gives them realistic expectations of the procedure, and the post-procedure care, and that it's not going to be we do the procedure and then you go sprinting off the next day. So that's been very helpful. Afterwards, I wouldn't have a problem with sending back to the referring doctor for post-procedure care, but I would want to discuss with them, kind of expectations and things to look for. But in my mind, as long as they're okay with it, I like to see them myself as well, just to make sure that everything from a procedural standpoint looks good. There's no side infection, anything like that. But I think it depends on the referral and how you kind of fill that situation out and how you need to work with them. But post-procedure wise, I think I'd still like to see them, but I wouldn't have a huge problem sending them back to the primary doctor. What are the pitfalls of the 10x procedure? One of the pitfalls, I think, at least initially, is just visualizing the tendon. And if you haven't done a lot of ultrasound of the tendons, you can kind of get some angle artifact, and you think there's a hypoechoic area that may not be real, and it's really just kind of seeing it a bunch of times to realize that what's actually thickened and what's the tendon, because I just hadn't done many tendon ultrasounds or really thought about looking at tendons on ultrasound before. So I think that's one of the pitfalls, is you may be able to trick yourself into a lesion that's not really there. But what I can tell you is that if you really put your finger and get that pinpoint tenderness and then ultrasound that exact area that you're pointing to that's eliciting the pain, there's usually something there that's hypoechoic, and it's pretty visible to see compared to the rest of the tendon. And in my mind, if you're seeing a lesion and you can't elicit pinpoint tenderness there, it's either not real or that's not what's causing their pain, and they're not going to get a benefit from the treatment. Otherwise, I haven't encountered really too many pitfalls. I don't know, have you, Mike?
No. Yeah, I would agree. It's actually kind of nice to get more interested into musculoskeletal ultrasound, which I don't think we do a lot here in the States. They probably do more in Europe. But this has sparked our interest to just scan normal areas of the body to evaluate the tendons, so that we know what's normal and what's not normal.
Okay. All right. The next question: how many procedures did you perform before you felt comfortable and confident with the technology and anatomy? I think the technology is pretty easy to feel comfortable with after the second procedure. There's kind of a tactile resistance that the reps and Jaggy really kind of told us about beforehand, and that we experienced with the cadavers, and you really do feel that, and after you feel it once or twice, you kind of understand, once you've got a successful treatment, the difference in the tactile sensation. And the anatomy, I started feeling confident after I ultrasounded about 20 to 30 different tendons on myself and our techs and pretty much anybody that hangs around in this department that we could force to get on an ultrasound table and let us scan them. But that's kind of an ongoing thing, and I'm starting to feel more comfortable now with rotator cuff. I think that was hard for me at the beginning, but once you see the tendons a few times in an ultrasound, I think you feel pretty confident with it. And really, it only takes, as an IR, I think a couple of times to do the procedure where you feel pretty confident that you can get the job done, and just learning kind of the limitations of the probe and how far that distance is and where you need to make your incision and where you want to puncture relative to the ultrasound to ensure ability to treat. Next question: when would you consider treating a patient with lesions years after an open procedure? I haven't had that experience yet or situation come up, but I definitely would. I actually think that after an open procedure, you probably do develop surgical scar tissue. And we were actually talking with one of our orthopods today about arthropfibrosis after a total joint, and would this be useful in that situation. So we're talking about trying it in that situation as well. But I think I definitely would if there's some scar tissue that's visualized under ultrasound, and I think that it's recurred due to that. I think this would be actually a great therapy for it. But I can't say that I've done it or had that opportunity. How many procedures have you performed to date? We've performed 5 at this institution, and we've done a lot in the last couple of weeks, seeing patients in clinic to get them scheduled for future procedures. So we have a lot coming up. Have you made any association with post-procedure pain with the time of actual procedure time? example, the plantar fascia patient that he treated for 20 minutes. You know, so far, what I've talked to a couple people that have done several more of these than I have, and they do seem to say that the longer treatment time usually necessitates a little bit longer recovery period, which seems to make sense to me. The more kind of tissue you're debriding, the longer it's going to take to heal up. But he did great. I was really surprised. A few days after, I thought he was going to be in quite a bit of pain. I was going to be calling him a narcotic. Actually, like I said, he's the CFO of the hospital. I gave him my cell number, and I was like, seriously, call me if you need anything. I'll, as the weekend, I'll, do whatever you need. And he called me to tell me he was feeling great. And then at 2 weeks, I called him, and he said, my pain's about 50% gone. He's like, can I walk my dog with this boot on? And I told him he could take the boot off and try walking his dog. And he did really great in it. I guess I saw him more closer to 6 weeks just due to some scheduling issues. And his pain's like 1 out of 10, and really all he does is stretching to kind of warm up actually a different spot of pain that he has in his foot, but he no longer has any pain related at the heel where he was having the pain before. So I can't say for sure that I see a definite correlation just due to limited experience, but I have talking to other people more experienced. I have heard that there is some of a correlation between the longer treatment time and recovery period. That's all the questions that I have here on the messenger. So I think now we're going to open it up to phone questions if anybody has some.
I mean, you touched on it a little bit, but how well was it tolerated? Did the patients have a lot of pain while you were actually doing it? Did you have to really be careful with your local anesthetic, or are they do they do pretty well with just the basic anesthetic prep?
It was very well tolerated. We just did basic local anesthetic. We injected under ultrasonic guidance. We injected lidocaine down, and it was extremely well tolerated. I mean, every patient was like, I can't feel anything.
Thank you.
Just had a question about any new areas. You mentioned the area that you're doing currently. Is there any others that you see coming in the future?
I think that there's a lot of different areas that this technology could expand into. I think right now we're in the infancy of it. Just today, like I said, we were talking with one of our orthopedic surgeons about arthroplasty that occurs after total joint implantation and going and debriding that. So I think post-surgical scar tissue is definitely an area that this could be applied to. And I mean, obviously it needs further investigation, but I think that would be one area. Another area I've thought about is potentially carpal tunnel syndrome, and whether or not you could try to use it in that instance, even though you are near the median nerve, but I think it could be useful there. And then, people are starting to use it in the shoulder, and I think that's a really big potential, especially calcific tendonitis of like the supraspinatus, I think is a potential easy spot for this. And pretty much any tendon or area that has scar tissue that is causing symptoms, I think this could potentially be applicable to.
Thank you for attending today's 10x Health webinar presentation. I also wish to thank the speaker for providing a very informative session. For future 10x Health presentations, please check with your 10x Health representative.